my expertise, which is in the use of ketamine to treat depression and different approaches to doing that. And a lot of what I'm planning to say, I think, is relevant to other kinds of psychospiritual exploration, but I'm going to try to focus on the thing that I know best. Originally, I was going to use some slides, but I'm not really in a slides kind of mood, so I think I'm going to just talk. I do have an outline here that I'm going to use so that I don't get too completely off the rails. But let's just talk. Let's just talk about this. So, and by the way, that meditation was so lovely. I was worried I was gonna slip deeply into a state of relaxation and miss my own lecture, but thankfully, here we are. I wanted to start actually by expressing gratitude to Dylan for reaching out to me, and also to my friend and neighbor, David Presti, who really is an inspiration to me, and in particular has done an amazing job of talking very seriously about spiritual issues combined with science, neuroscience in particular, and really is an amazing leader in our field. I look up to you, and it's really, really an honor for me to get to be here today with all of you. So let's see, let me tell you a little bit about myself, about my background, just to contextualize what I'm going to say. I have a doctoral degree in clinical psychology, and I'm a ketamine specialist, and I live here in Berkeley. And my actual training is in the diagnosis and treatment of people who are living with severe or refractory depression, or people who are living with unusual presentations of bipolar disorder, or people who are living with active suicidal ideation. And as a psychologist, psychotherapist, I was frustrated with the tools that were available to me, namely psychotherapy and collaboration with psychiatrists or hospitals. They're quite effective, but they take too long. And I was fascinated by the rapid acting properties of ketamine, which I had personally encountered back in 2002, so really a long time ago. And in fact, at that time, when I first had experienced ketamine, I thought to myself, dang, this has some rapid acting antidepressant properties. And the people around me said, no, that's not possible. It's not possible. They said at that time, it's not possible to have an agent, a chemical or a medication that has a beneficial effect that is rapid acting, that affects mood and thought profoundly in a rapid way. They said that doesn't exist and it will never exist. And I thought to myself, that can't be right. That's not right. I had friends and classmates who were using a lot of cocaine and heroin, and it seemed to me pretty obvious that there are medications that rapidly have a profound impact on perception and mood. In those cases, usually in a direction that is maybe not so helpful. But it did seem to me that it had to be conceptually possible that there would be something that was equally rapid acting that helped in a beneficial way. And so that's really what I wanted to study. So anyway, just to say, I've been studying this topic for since 2002, so for 18 or 19 years. And in my actual clinical practice, I work in collaboration with medical professionals, with physicians and nurse practitioners and other folks. And that's what makes it possible to provide legal administration of ketamine for certain psychiatric indications. Oh, and as we mentioned earlier, I'm also the proud founder of KRIA Institute and KRIA Conference. You can check out the website if you like. Both of those organizations are devoted to understanding the use of ketamine in psychiatry and psychotherapy. Anyway, moving right along here. Let's see, I think I'm going to talk today about different approaches to ketamine treatment. That's going to be kind of the essence of the talk. I'm going to then talk a little bit about current legal clinical indications for ketamine treatment. And then I'm going to follow that up with a little bit more on the nuances of the legal status of ketamine. And if you have questions, please put them in the chat, and then we'll come back and we'll answer them all at the end. I turned my chat off so that I can focus on all this interesting material, but hopefully someone's going to track that for me. Yeah? Okay, great. Let's see here. So let's get right into it. So you probably know this. Ketamine is a chemical that was originally developed in the 1960s as a surgical anesthetic for humans. Um, and often was talked about as a surgical anesthetic, but actually it's a glutamate modulator. It's a medicine that affects the glutamate pathway in the brain. Side note, glutamate is the most abundant neurotransmitter in your body and is essential for movement, memory, and learning. And it turns out that it's also critically important for mood. You don't hear glutamate talked about a lot with respect to mood. It's not one of the sexy ones. It's not, serotonin or dopamine. They're mentioned more often with respect to mood. But it turns out that glutamate and its cousin GABA are of central importance. And I actually think that ketamine is the first of a whole new wave of glutamate modulating medication that's in the pipeline that's going to be developed and that's coming in in the next couple of years. Anyway, so in addition to being a glutamate modulator, ketamine also has rapid acting antidepressants and anti-obsessional properties, and actually works in about less than 10 minutes when it's administered correctly, like really rapid acting. Um, and you probably have heard this, ketamine also has some pretty profound dissociative and psychedelic properties. Um, in fact, it's not unusual to hear clinical patients report that when they received ketamine, they believed themselves to be in the presence of God, um, or different variations on that, or they talk about their own sacredness or divinity or the sacredness of their life. And this is pretty fascinating, particularly in people who are in treatment because they were wanting to end their life. And so this is absolutely fascinating. And so that's actually what I study. I actually study the relationship between mood modulation and psychedelic experience. Um, and so the other thing I wanted to say by way of introduction to ketamine is that it's dirt cheap. It's about $1.59 as a medical supply for anesthesia or in pain management, and now for depression for a single substantial dose. So that's like dirt cheap, like dirt cheap. And so it's a puzzle to me why we're not using it even more frequently than we are, because it's economically very efficient. Okay, moving on. Let's see here. Okay, so I said I was going to talk about ketamine treatment for depression and for other related psychiatric issues. I want to point out to you, as we talk about this, that there's a couple of different variables in ketamine treatment. I say this because there's a lot of disagreement about how to use this tool in an optimal way, a lot of different and competing ideas. And so it's important to figure out what the variables are. So here's the thing that the clinicians can control in providing ketamine to a patient. They can control the route. In other words, how the ketamine is put into the patient's body, the route. They can control the dose, how much ketamine, how much ketamine is put in at one time, what the quantity is, and what your beliefs are about what's most helpful and appropriate. Another variable here is the frequency of the clinical sessions. In other words, how often should you be doing this, or how often should the body be exposed to ketamine? That's an important question. Another really important variable in clinical ketamine treatment is the setting. It turns out that the setting is a critical variable for a good outcome, and one that's often overlooked or underappreciated. So I want you to pay attention to that as we talk further. And then the last variable, the last thing that the clinician can control, is something that we call clinical presence. That means the person who's in the room when the ketamine is being administered. What do they think their job is? What do they think they're supposed to be doing? Let me give you a couple of different ideas about that. Some providers are very focused on beeping monitor things and very focused on maintaining the patient's or the journeyer's physical well-being. And that's certainly important, but I don't think that's the whole story. Other folks think that what they're supposed to do is to be a guide, a psychedelic guide. In other words, to sit back quietly and to be as unobtrusive as possible and to radiate a loving presence and maybe take some notes. but to basically just kind of disappear into the wall, and certainly not introducing topics for exploration, because that would be intruding too much on the journey. So that's a different idea about clinical presence. And yet a different idea is to do ketamine facilitated psychotherapy. And so this really only occurs when there is a existing relationship between the client and the therapist, and where the therapist has a pretty good sense of the internal landscape of the journeyer or of the patient, and the therapist has permission to introduce or explore sensitive topics with the patient, and the clinician has the skills, has technique-driven skills to know how to navigate that sensitive terrain in a way that is ultimately going to benefit the patient and not cause them any harm. Anyway, I say all that to say that there's these 5 variables that we need to be thinking about with respect to treatment, or really with respect to any psychedelic exploration. Have you been attentive to these 5 things? Anyway, um, oh, I did want to make a specific note about the dose. This is important. A really important concept in thinking about the dose of a medication is bioavailability. Bioavailability. I don't know if you've heard this word before, but bioavailability refers to the amount of a medication that makes it to the target organ to do the job that it was intended to do. So with respect to ketamine treatment, bioavailability specifically refers to how much ketamine made it to your brain to exert an antidepressant effect. And the reason that this is important is because each route of administration has a different bioavailability. Each route has a different bioavailability. So if you put the ketamine directly into somebody's vein, like in an infusion, an IV, probably 97% of that medication makes it to the patient's brain. And similarly, if you give the patient an injection of ketamine into a big muscle, probably 93, 94% of that makes it to the brain to exert the therapeutic effect that you're hoping for. It's so close to 100 that we don't even convert it. We just, if you, that's considered high bioavailability. But here's the thing you need to know. When you start putting ketamine into the nasal passage, when people are insufflating it, the bioavailability is estimated at 40%. But it's actually really variable. It varies from person to person and even day to day. And it's actually probably somewhere between 25 and 60% bioavailable. Similarly, if you have the patient take a compounded lozenge, it's like a piece of candy made at the pharmacy that has ketamine put into it, and then you have them put it in their mouth, and then they hold it in between the gums and the cheek, and then the medicine is going in through the vasculature of the cheek or under the tongue. Again, estimated at 40% bioavailable, but really could be anywhere between 25 and 60% bioavailable. So from a clinical perspective, these other routes, the lozenges or the nasal spray, is really undesirable. It's challenging because the clinical effect is varies so much, and hard to get the patient right where you want them with respect to dose and effect. So I just say that so that you understand that getting an injection of 100 milligrams of ketamine is not the same as taking a lozenge that has 100 milligrams of ketamine into it, and then you put it in your mouth. Only in one of those cases are you getting nearly 100% of the medicine to your brain, and in the other case, most of it is lost in metabolism. Does that make sense? Yeah, it's really important when thinking about clinical treatment. Anyway, okay, let's continue on. So I think I said that there's a lot of controversy and disagreement about how to use this tool. And so what I'd like to do now is to go over with you the 3 dominant paradigms in the clinical ketamine world. So the first one is the research protocol. It's sometimes called the NIMH protocol, National Institute of Mental Health. And so a vast majority of the research studies that exist have been done using this protocol, which is why it's important to know about it. So in this protocol, the patient receives 0.5 milligrams of ketamine per kilogram of body weight by IV infusion in a doctor's office. And usually it's on a drip that runs 40 minutes. There's nothing magical about that. That's just what the protocol is. And here's the thing. The thing is that this protocol was designed to be sub-psychedelic, below the psychedelic effect, non-twinkly, on purpose, because the psychedelic side effects of ketamine, or the psychedelic effect of ketamine, is considered in this protocol and in this paradigm. It's considered to be an annoying and problematic side effect to be avoided at all costs. So either you dose under the psychedelic effect, you just drop the dose to avoid, God forbid, psychedelic experience. Don't let the patient talk about anything psychospiritual. That would clearly be bad. I'm kidding. Or if it happens, then you medicate them to make sure that they're not talking too much about their experience of their own divinity, because that also sounds psychotic. I mean, we can't have that. So anyway, sub-psychedelic dosing, 0.5 mg/kg IV. And this works some of the time for some people with depression, but truthfully, the dose is too low and it's not durable. It doesn't give a great antidepressant effect for a lot of folks. So to get around this problem, or to compensate for it, the research protocol is to give 6 infusions of ketamine back to back in a short period of time, like in a 2 or 3 week span. So 6 infusions, 6 separate sessions, with the intent of avoiding psychedelic experience in any individual session. So the idea is to make it cumulative and to get enough ketamine into the patient's body to do the magic thing that ketamine does, to get the right quantity in, but to basically divide up the dose so that it's sub-psychedelic. Does that make sense? You with me? And the patients vary in their experience, but one thing that's reported pretty commonly is patients say that it feels akin to drinking 2 glasses of wine on an empty stomach. It might make you feel a little bit nauseous and a little bit sleepy and maybe a little bit silly or disinhibited, but the patient clearly knows who they are and where they are and what's happening to them at all times, and they can carry on a conversation with you. They are not experiencing full dissociation. They're like a little bit intoxicated. So I just want you to know what this is, so that if you go and read the research about this, you know what you're looking at. Anyway, here's what I want to say about this paradigm, about this approach. It fundamentally is a medical or surgical or Western approach to treatment. And so when you read papers about this, the emphasis in terms of the mechanism of action, the emphasis is clearly on what's happening at a chemical level, at the level of the receptors, at the level of the neurons. Some people even branch out and talk about the brain regions, but it has a very cellular and biochemical focus. And I also want to point out that there's no psychotherapy in this model. It's not considered important or valuable. It's not happening concurrently. So the psychotherapy is put to the side. And as I said, the psychedelic properties of ketamine are considered a problematic side effect. And so, yeah, there's no doubt that ketamine does something at a chemical level that is valuable in treating refractory depression or obsessional thoughts. But I don't think that's the whole story. And my concern about this approach, I have a couple concerns. The first concern is that the effect of the ketamine, the beneficial effect, is temporary and it wears off. It has sort of a prominent effect when it's done correctly for about a week, and then like a little bit of a tail that kind of goes on another week. So maybe 2 weeks max, on a good day. If you cluster the treatments together, you can get more than that. But eventually the effect wears off. And if you haven't taught the patient any new tools, then they're just going to be dependent on coming back for ketamine treatment ongoing. And I have a concern about that. The other challenge here is that this type of approach, this kind of mentality, it forces the patient into a passive position, such that the patient isn't being called upon to do anything in their own treatment or to work on their own behalf. So all the patient has to do in this model is to somehow show up for the appointment. But beyond that, they just sit there passively and receive the magic medicine that then does all the work. And so that's fundamentally a surgical or a Western approach to medicine and to treatment. So this is a perfectly good approach to certain kinds of medicalized interventions. Great for surgery, might even be good for antibiotics or chemotherapy. But the question is this the best way to help somebody who's having an ongoing mental health problem? Do you really want them to be passive, or do you want to empower them to participate in their treatment more? So you can just chew on that as we continue to talk. By the way, I wanted to also mention that Spravato or S-ketamine, this new product from Johnson & Johnson that got FDA approval last year. So it's nasal spray. It's a filtered ketamine product, and you put it up your nose in the doctor's office. And it's insanely expensive. It's $850 for a single session, as compared with the $159 that I mentioned before. Yeah, we should all be totally outraged. That's, excuse me for saying so, that's medical extortion. But anyway, sorry, I'm a little bit of a hot potato. Uh, where were we? I just wanted to point out that the S-ketamine trials were all done using the same research protocol as the infusions that I just described. But instead of putting it in an infusion, or instead of using an IV, they administered nasal spray instead and compensated for the poor bioavailability. Um, but anyway, so this Spravato studies are the same fundamental approach with the same embedded biases. Okay, well, I think I talked about the cost. Okay, so let's move on. So what I'd like to do here is I'd like to talk with you about a different way of using ketamine. It's the same medicine, it's just a different paradigm, a different fundamental approach, a different framework, if you will. So the one that I want to talk about next is ketamine facilitated psychotherapy. Remember, in the infusion model and in the esketamine model, there is no psychotherapy. But here, in the thing I want to talk about next, that the psychotherapy is central and essential. So in ketamine facilitated psychotherapy, the emphasis is on the psychotherapy process. In other words, the healing agent is understood to be the dialogue between the therapist and the client. And the idea is to use the ketamine as a lubricant, or to use it as a catalyst for getting to material, psychological and emotional material, that is too difficult to get to otherwise. And so the idea is to put the ketamine in and then help the patient to relax and talk more deeply and think about themselves internally, or think about their internal world. So again, it's the same medicine, it's just a different approach. And so this is done often with injection or with a lozenge in the therapist's office. This needs to be spaced out with weeks or more in between each session, so that people have time to process or integrate what they've covered. And what you actually see with this is that patients often describe this experience as being pleasant and relaxing. They often say that it's easier to talk. And what you actually see is patients sort of rarely wander into new or novel territory. Actually, what happens is they tend to revisit material that they've already discussed previously in psychotherapy, but it seems like they grasp it in a different way, or in a way that is more durable. I have a lot to say about this, but let me. I think that's a taste of it for now. Anyway, this approach to working with ketamine is fundamentally a psychological and a relational model, where both people in the room, the therapist and the patient, are both working equally hard and working very hard on the patient's behalf. But the workload is split 50-50 between the two people. So that's a really key difference between the infusion model and the psychotherapy model. So as I said, here the psychotherapy is emphasized as central and essential. You're still wanting to dose people in a sub-psychedelic range. Because if they get too far out there, too dissociated, then they're either A, not going to want to talk to you, or B, worst case scenario, forget that they have a mouth. And so then you can't really do the ketamine facilitated psychotherapy if they're they're onto a different plane of existence. So the dose is still dosed lightly. Um, anyway, you get the idea. The challenge here, the challenge here is that psychotherapy is expensive and it takes time. And that's a real limitation to this model when you think about having access for the whole community and you think about cost and you also think about the urgency when people are really severely depressed. And so this has its strengths and its drawbacks, as every model does. But anyway, you get the idea. Okay, so the therapy is central. By the way, I'm going to I'm going to defer to David on this because he might know more about this than I do. But it does appear that there's a neuroplastic window, specifically a window where the tips of the dendrites of the neurons, the tips of the cells in your brain are sprouting out and making new connections like that. That appears to last about 2.5 days post ketamine administration. And in that window, it appears that learning is very potent. So that's exactly the right time to be doing ketamine facilitated psychotherapy. It almost looks like the new learning is getting wired in. I'm not totally sure about that. I'm not a neuroscientist, but there's a lot of interesting research coming out about this. What I want to say about this is that from my perspective, the goal is to combine the ketamine treatment and psychotherapy such that the patient gains more tools in their toolkit and is not dependent on ketamine forever, but rather it's true. Some people may need medication lifelong and they absolutely should have it, but that's a minority. The majority of people probably can and should get off meds and be growing psychologically, spiritually, and emotionally throughout their lives and gaining new skills. So that's the goal of the treatment. Okay, the next thing that I want to talk about, I think I covered that. The next thing that I want to talk about is the reason we're all here to talk about psychedelic ketamine journeys. So again, I just want to clarify it's the same medicine, but it's a different paradigm. It's a different framework. It's a different set of values in the treatment. So here's the thing. Um, some patients, some clients really are a good candidate for a full-blown psychedelic and dissociative experience. And it's a much smaller fraction of people than you would think actually are who are a good candidate for that out of the gate. But in this kind of approach, a couple of things have happened. The provider believes that mystical, dissociative, and psychedelic experience, the provider believes that this is valuable, not an annoying side effect to be avoided, but rather they believe that these mystical visions can be informative and useful and beneficial. Excuse me, and potentially healing. So they're actually aiming for that. They're inviting it in. And also, the other thing that has to happen is that the patients have to be very carefully selected to make sure that they're appropriate for this. And also, there has to be special psychological preparation because otherwise, this kind of experience could be very disorienting or even scary if people are not adequately selected and prepared. Anyway, the idea here is this is typically done by injection somewhere in the 1.0 to 2.0 milligrams per kilogram bioavailable range. You got to do the math. Um, and typically done in the therapist's office. Sometimes it's done in the client's home if they're ill. And so I'll tell you what it actually looks like. We keep people with us for a minimum of 4 and often upwards of 6 hours at our office. And so, and again, I just want to say again, so that I'm being as clear as possible, before we get to the medicine session, me and my team have had multiple sessions with each client to go through an intake process and then a psychological preparation process, which may span multiple sessions or meetings. Okay? It's not like we do this on the first day. But anyway, when we're actually doing a psychedelic ketamine session with an individual or a group, there's obviously check-in time, and then the medicine is offered. And the medicine comes on in like less than 5 minutes. It's a very rapid onset, to be followed by roughly 75 minutes, give or take, of what we call active medicine, where the journeyers or the clients are typically lying down and partially immobilized. Don't forget it has the anesthetic properties, and are having colorful, dream-like visions for about an hour, hour and a half, give or take, to be followed by another hour at least of sedated recovery, to be followed by multiple hours of rest. So anyway, as I said, it takes 4 to 6 hours to do a session like this. And the client's experience is one of full dissociation, often or full or partial dissociation, but where the sensory input, where the input from the sensory organs rather is quieted down, and instead the imagination or the internal wisdom or consciousness is liberated in such a way that it's making visions and conveying information visually, is kind of what happens here. So anyway, when this is happening, the usually the providers are sitting back quietly, more in a psychedelic guide stance, but then go on to do psychotherapy later that day or the next day, and the other treatment that follows. Anyway, what can I say about this? Here, I just want to clarify that the psychotherapy is not happening during the act of medicine. You wouldn't be able to do that effectively. But there is a lot of psychotherapy sandwiching it before and after. So that therapy is essential. It's just not right when the medicine is peaking. And so here, obviously, in this paradigm, the psychedelic experience is central, valuable, essential. It's kind of like where it's at. The challenge here, the challenge here is that first of all, this would not be appropriate for lots of people. Um, And so if you want to learn more about that in greater detail, you can reach out to me or take one of the trainings. There's a whole list of trainings on my website. Maybe we'll put that up in the chat at the end so you can see that. But the other thing to appreciate is that the risk level, the level of risk for some sort of physical or psychological bad reaction or emergency goes up as the dose goes up. So while ketamine is considered one of the safer anesthetics in the lower dose range, as you go higher, there's a lot more bad things that can happen. And as the provider, you're responsible for that patient's life. And it's really important that the provider and also the journeyer fully understands the risks involved in this kind of exploration. And again, the sort of the nuances of that or the details of that are outside the scope of this particular talk, but that information is certainly available in one of the trainings. Let's see, do I have anything else I want to say? Yeah, I guess the other thing I'll sort of say about that is that I happen to believe that in every psychedelic journey, there is an actionable step. There's a message in the medicine, and the key to having the key to really, it's really important that clients and journeyers and patients, I'm using those words interchangeably, that they listen for or look for the message about what they can do differently in their daily lives to move themselves toward wellness. And it's that actionable step, that thing that they're going to be working on. That's what differentiates recreational ketamine use from therapeutic ketamine use. And so, providing the patient with assistance to find the message and then to implement it, that's really, I think, where it's at in terms of therapeutic ketamine. Let's see here. Anyway, let me just let me just gather my thoughts here for a moment. So let me just recap what I've said so that we're all on the same page. I've just outlined for you 3 different approaches to therapeutic ketamine treatment. And in the first one, the ketamine with the infusion approach and with the nasal spray, in terms of how it's dosed, the ketamine is being used as a pharmaceutical. The emphasis is on the biochemical properties of ketamine. And then in the second thing that I said, I was talking about ketamine facilitated psychotherapy. And there, the emphasis is really on the psychological metabolism of emotional material. And the emphasis is really on the psychotherapy. And then in the third thing I said, we were just talking about psychedelic ketamine experience and psychedelic journeys. And in that paradigm, the emphasis is on the vision content itself, on the vision experience, within keeping in mind that there are some special safety parameters here. So, people often ask which of these approaches works the best, or which, as a client, which service should they seek? As a provider, which service should they provide? And so I want to answer that question right now by saying that all of the paradigms are valuable, and that all of them work some of the time, but none of them work all of the time. And so, from my perspective, the competent ketamine provider has a working knowledge of different routes of administration and different dosing strategies for ketamine, and then matches the treatment to the patient. So, I think where we're going with all this in the field is to appreciating the spectrum of ketamine services. Let me pause there and just check in with Dylan for a quick second. Dylan, how are we doing on time?
We still, I mean, we're still booked for a full hour if you want. We do have some questions in the chat, but they say that they're for the end, for whenever you want to take those.
Okay, maybe I'll talk for a couple more minutes and then I'll wrap it up. Uh, a couple of other things I wanted to make sure I said today. Okay, good. Just thank you for that. I want to just make sure that we mention today when you would do this, when it's legal and legally defensible to provide ketamine treatment. I want to make sure we touch on that. So, um, here's the thing. There's a lot of existing literature in the academic and research literature about the use of ketamine for 5 specific indications. So here's when we think it's clinically appropriate: if the patient has severe and refractory major depressive disorder and they've failed other treatment, if the patient has bipolar depression, if the patient has a lot of physical pain or injury with depression, those things often go together. If the patient has obsessive compulsive disorder, or if the patient has something called ruminative suicidality that has an obsessive quality to it. I just want to say a quick note about that because it's easy to get confused about that one. We do not mean that we do not, what we're not talking about is people who become suicidal in response to a clear stressor. Like, and COVID is such a great example of this. It's hard to sort out what's endogenous and what's situational. But anyway, what we're talking about is people who have suicidal thoughts, self-harm thoughts that are intrusive and distressing to them and repetitive. And as I said, it has an obsessional quality to it. Those folks tend to benefit from ketamine treatment. We also think that ketamine might be useful for some other stuff that we're studying. It's not as clearly established in the literature, but we're looking at the use of ketamine as an adjunct to treat anorexia, and a variety of other things. We're looking at the possibility of using ketamine to treat other kinds of substance use disorders. In other words, other kinds of addictions. That gets a little tricky. And then there's this question of if ketamine is helpful in treating PTSD, and that's a big question, so I'll save that for a different day. The findings are mixed and nuanced. And then, of course, there's this interesting question about, is ketamine useful for psychospiritual exploration and personal growth? I mean, this is like the key question. And there's no doubt in anybody's mind that that ketamine might be useful as an adjunct to psychotherapy for that purpose in the absence of a psychiatric disorder. But the problem is that it's not exactly legal. It's not legally defensible. And let me just tell you why really quickly. I need to explain something here. The thing, I just want you to understand this, or just get a taste of the fact that this is a nuanced and complicated topic. Just to say that there's 5 forces that shape what a clinician is allowed to do legally, or what services you're allowed to get as a client. And those 5 forces are the DEA, the FDA, the state board that controls the provider's license, the research literature, and liability insurance. So I know this gets a little boring, but just to say that if you do, the ketamine is in DEA Schedule 3. But that's not the end of the story, because if you do anything as a provider that the state board doesn't like, they have the state board has the right to call you in and audit you and to either suspend or remove your license. And at this point in time, the only things that are legally defensible in front of the state board is if what you do as a provider is supported in the academic and research literature. So now we circle back to the question, there's not a lot written about the use of ketamine for personal growth. And until that's in the literature, in the research literature, it's not legally defensible. And therefore, the fact that it's in DEA Schedule 3 is not enough to protect the provider. So we're in a really critical moment in history and in politics as things are shifting. And again, I'm happy to go back and explain this to you again in more detail. But just to say that the DEA scheduling is not the whole story, and it's actually not currently legally defensible to just give ketamine willy-nilly just because the patient wants it. Uh, that's you're actually not allowed to do that. Anyway, let's see here. I guess I'll wrap up my lecture by saying just a few final thoughts. Um, Here's the thought. Uh, the thing is that the patients who get well and stay well over time are people who are doing a lot of stuff, a lot of integrative treatment in addition to ketamine. So I'm pretty famous for saying that ketamine should never be more than 1/10 of the treatment plan. And I think we should all be highly suspicious of any provider who wants to sell you ketamine infusion alone and doesn't mention the other things that people need to do. But the other things that people need to do to stay well is some combination of the following, or might include the following. So individual psychotherapy or a support group. A lot of people take oral conventional medication. We often look at people's sleep schedule. We also encourage people to exercise. That has great antidepressant properties. We're often looking at what people are intaking, or rather their diet and nutrition. Really valuable to teach people meditation and learning the skills to observe your own thoughts and mind. Um, People need meaningful activities or work to do. They also need social and recreational time. It's valuable to cultivate a spiritual practice of some sort and to contemplate these questions about meaningfulness. Um, People benefit from getting out into the sunshine and out into the light and out into nature. And then we sometimes add ketamine treatment. So again, ketamine should only be 1/10 of the treatment plan, not the thing that you're relying on to stay well. And that's why I have grave concerns about people who are trying to self-treat at home using ketamine. Uh, Unless you've got those other elements going, that's I think that's potentially problematic. And just by the way, at least half of the things that I just mentioned happen to be free, so that's always a plus. Let's see, what else do I want to say today? Yeah, I guess I'll just end by saying that on my website on for Kriya Institute, you can find a ton of free resources for clinicians and for journeyers. There's a bunch of articles and videos, and there's like my favorite journey music. There's a list of trainings, there's books on this topic, etc. Um, so tons of free information that you could make use of if you wanted to. So I think I'm going to stop there and just thank you for listening. And I would love to take some questions.
Thank you, Raquel. Yes, thank you, thank you. Um, okay, yeah, Noah just linked the Korea Institute website into the chat, so everybody feel free to peruse that. A couple questions that are posted in the chat. Oh, I do want to remind everybody, if you want to just like say your question, you can use the Zoom raise hand feature or just like unmute yourself. Or if you want us to read it off, put it in the chat. But so this question was about the indications. Yeah, does ketamine have potential to treat anxiety problems, and are there any negative long-term effects of prolonged use? And this is from Guy. Thank you,
Uh,
Guy.
Yeah, thank you for the question. It sounds like there's two questions there. So the first question is about people with prominent anxiety. So here's the thing. The thing is that um, the findings have been really mixed, and people who have a lot of somatic anxiety or psychological anxiety, it appears that about 50% of them feel helped by ketamine treatment, and they talk about feeling soothed or downregulated in a way that feels helpful. It's also temporary. But the other 50% finds ketamine to be too agitating and stimulating. It definitely has some up and it has some down properties. And so this is always the challenge, is that for people who have a lot of anxiety, we have no way of knowing at this point whether the ketamine treatment is going to feel helpful or whether it's going to make things temporarily worse. And so, if we're treating people with a lot of anxiety, it's really important to have some sort of anxiety management plan in place so that in the case it does get a little too stimulating after the session, the patient kind of knows what to do to manage themselves. That said, I don't think that ketamine is the ideal medicine for treating anxiety. I think what we're going to see is some other sacred medicines are going to be more useful. But this is what we got for now. And so it's just worth it to know that the findings have been really mixed. Then somebody else, then you asked a different question, which is long-term use. Are there any problems? And the answer is yes. The biggest problem that I'm worried about, that we're all worried about, is cystitis, which is irritation, pain, and dysfunction of the bladder or kidneys secondary to too much ketamine exposure. So it would appear that the presence of ketamine um, prevents let's see here, the mesothelium, the middle layer of the bladder, from differentiating into endothelium, or lining of the bladder, which is a fancy way of saying that the bladder feels stripped and raw if you use too much ketamine, particularly ketamine over time. And that can be a very serious, painful, and functional problem. So we all need to be thinking about, as I said, balancing ketamine use with these other interventions to help keep people safe and well over time.
Cool. Thank you. Another, I mean, just while we're talking about like indications, there is another question about somebody having read benefits or potential benefits to individuals with ADHD. Um, but I think just more, so I want to convey that question, but just more broadly, I guess what I'm wondering is, so like I'm hearing the indications, but I'm still a little fuzzy on what specifically separates ketamine assisted psychotherapy from other sacred medicine assisted psychotherapy, and how is the, like, what in, like, for which people would you recommend this type of thing, and that sort of question, I think, just to sort of generalize these sort of questions I'm seeing.
Okay, let me see if I got that. I, 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 mm, Let me take a crack at that by saying that I really look forward to the time, which I think is going to be in the near future, where medical and mental health professionals have a whole variety of tools, including a variety of sacred medicines in their toolkit that they can use, rather than just being restricted to, like, basically just ketamine. And so, I actually think that that's coming with MDMA and psilocybin and even LSD research. I think we're getting there faster than anybody anticipated. Um, I think we're overusing ketamine right at the moment because that's the one that's more easily available. And I think other folks in the ketamine in the clinical community have overpromised. And I think that what we're going to see in time, everything's going to shake out, and we're going to see that the different sacred medicines have different primary indications or things that they're optimal at. So ketamine is really optimal for primary organic depression, the more body heavy neurological depression kind. Ketamine, you get a lot of bang for your buck most of the time with ketamine treatment um, for that specific thing. But it's not clear that ketamine is helpful or appropriate for mild depression or even moderate depression or stress or anxiety or grief. Not clear that it's helpful for any of that stuff. So we're still investigating that. Um, so yeah, ADHD is not currently one of the indications for ketamine. I don't know what the future research is going to show, but uh, to date, that's not in the literature.
Cool. Thank you. Oliver, do you want to ask your question?
Yeah. Hi. I had a question kind of more on the kind of the qualitative effects of the psychedelic experience with ketamine. I'm wondering like how you've seen it differ from other psychedelic medicines like LSD or psilocybin, and yeah, just any thoughts that you have on the differences between those medicines.
Oh, that's such a great question. Let me just think about that for a quick moment. Well, okay, so all the visionary medicines, or most of them anyway, have in common that they invite and induce an altered state of consciousness, an altered state of awareness that can be very generative and information rich. So in that sense, they're similar. But that said, ketamine is really quite substantially subjectively different than some of the other medicines you just mentioned. And let me try to say more about that. The thing is that that medicines like MDMA and LSD, which are primarily serotonergic, in other words, primarily have a lot of activity in the serotonin pathway. One of the things that those medicines are really good at is you can you can almost it's almost like taking a psychological or psychospiritual magnifying glass and focusing in, or there's the potential to focus in on some specific aspect of a person's biography or history or story or identity, and really put it under the microscope, put it under the magnifying glass, and really take a good look at that piece of the puzzle and really kind of work it out. The serotonergic medicines lend themselves to that kind of to introspection that kind of takes you into your story. And in contrast, ketamine does something completely different. Ketamine takes you away in the opposite direction, like going outward, away from who you think you are and from the story of what happened to you, which really just doesn't matter anymore up in the transpersonal ketamine space. The best way I can explain it, a lot of people say this, is imagine that you are a bird standing on a beach, with grains of sand, and that you fly upward. And such that you lose sight of the individual grains and fly upward and fly upward and fly upward and fly upward and fly upward. As you move toward dissociation, you no longer see the grains of sand, and at some point you don't even see the beach anymore. It's like that. Ketamine is dissociative and has the ability to take people. It has to be done correctly, first of all. That's an important point. But it takes people away from their self story, which can be a great relief, and sometimes away from their suffering temporarily, and often launches people into some sort of transpersonal space where it's hard to deny that everybody and everything is interconnected and interdependent. So anyway, that's so is there potentially some overlap between LSD and ketamine? Well, sort of, and yet they really are quite profoundly different. I hope that answers your question.
Yeah, thank you for your response. I was just thinking while you were saying that I feel like even with some of the serotonergic medicines that they can lead to like an ego disillusion, which I feel like is similar to what you were just talking about of flying above. You know, I think that I see there being an overlap in that sense.
Yeah, could I mean sure. Yeah, there's a lot of common themes that tend to emerge with these sacred and visionary medicines.
Cool. Thank you for that. And thank you for your question, Oliver. Another one from the chat. This is another question from Julian. Um, So this one is related to yeah, so glutamate, GABA. Okay, so would you know specifically where the ketamine acts the most in the brain? Is it similar to GABA? You mentioned not disrupting the journey. Have you noticed there's anything that's beneficial to being? Oh wait, never mind. This is a separate question. It's just a lot of questions at once. Okay, so this question is about yeah. So do you know specifically where ketamine acts the most in the brain, and is it similar to GABA? That one.
Yeah, I'm not a neuroscientist. We may need to get help from Dr. Presti on this one. I know I have lots of articles in my computer that explain all this stuff to me, but I can't seem to remember more of the like biological, cellular, and chemistry stuff. So the answer is I don't know off the top of my head, but I'm sure we could look it up with respect to the brain regions that are activated. And then GABA and glutamate convert into each other. They're both neurotransmitters that convert and are related in some important way through an enzyme process. And again, I'm not a neuroscientist, so I'm probably not the best person to try to explain it. But just to say that that information is available on the web. And also, I want to say two other things. I want to say that there's a lot about this about ketamine and all the other medicines that we totally don't understand. Uh, and part of it is actually something that I want to is a page I took from Dr. Presti's book, which is something called anti-reductionism, which is essentially the concept that naming all these molecules and receptor complexes and stuff doesn't may not adequately explain mental phenomena or mental experience. And so I'm not a big fan of trying to understand what's happening on the cellular or biochemical level, because I don't think that that gives us a complete picture of self-awareness and imagination or cosmic connection. So my answer is I don't know, and I'm okay with not knowing.
That's a great answer. I mean, just to add to that, Raquel, that first of all, it's beautiful. I'm not sure I can add anything. I can reflect a little bit on what you've said. I mean, I have to say, the more I learn about molecular neurobiology, the more skeptical I am that it is providing, the kinds of solutions or even insights or even sometimes steps forward that folks are hoping for at this point. It's so complex. So with respect to something like ketamine, as Anthony just pointed out, it's an antagonist at a certain kind of glutamate receptor called the NMDA glutamate receptor. And glutamate is everywhere in the brain. There are tens of billions of nerve cells that use glutamate as their neurotransmitter, and it's distributed throughout the entire brain. And then you can look and see where the NMDA glutamate receptors are most concentrated, and they are most concentrated in certain areas. And I know people have, and I'm not facile with all those answers too, but as Raquel, as you said, there are lots of papers that that speak to this, but there's a prevailing hypothesis that there's something about a concentration of NMDA glutamate receptors in regions of the thalamus that have to do with gating sensory input to the body, and that when those are blocked by, say, ketamine, it is the kind of the mechanism of part of the mechanism of the dissociative effect, which decouples your consciousness from body sensations in some way, and that may be of relevance to understanding it in some way. So that's there. Just as with the serotonergic psychedelics, it's not just about the serotonin, it's about the location of the 5-HT2A receptors, which are the major site of the action of the classic psychedelics. And so where are they concentrated? And they're concentrated in certain layers of the cerebral cortex. And that has given rise to theories that may be relevant to understanding their systems and behavioral effects. As to the relationship with GABA, glutamate is the most abundant neurotransmitter in the human brain, and GABA is the second most abundant. So it is also everywhere, and so and GABA is made from glutamate in one step. by an enzyme which is pervasive, but not everywhere. It's only found to be active in cells that actually are using GABA as the neurotransmitter. But there are tens of billions of those cells, and they're all over the place too. So it's complicated, and the danger of the reductionist neurochemical explanations for things is people get too carried away too quickly and think that they've understood the mechanism of how some sacred medicine, for example, is acting. And that leads to kind of an illusion of understanding about this absolutely, transcendentally powerful stuff sometimes, and in a way that we're nowhere close to.
Yes to all of that. I don't want to throw a monkey wrench into the works here, except for one little thing, which is everybody's very attached to the idea that ketamine is a glutamate modulator. I think I said that earlier in this talk, and we've all been promoting that, except for one little thing, which is that Big Pharma has tried to develop several other glutamate modulators and NMDA receptor antagonists that actually didn't work. And so there's some question as to whether, currently there's some question as to whether the glutamate modulation hypothesis is in fact the best explanation for ketamine's efficacy. Anyway, I'm just resigned to the fact that this is beyond what I'm going to understand in this lifetime. I know a little bit about it, but I'll tell you the truth. Maybe we'll end with this. First of all, I'm mostly interested in what I can observe with my own eyes. So what I've experienced in my own body, what I can hear and what I can see, what I can hear from my colleagues, what I can see in my patients. For me, that's clinical efficacy because you can observe the change from the time the patient walks in to the time that they leave your office. So I'm really interested in the observable phenomena. So that's part of it. I don't worry so much about the neuroscience. Let somebody else worry about that. But I was going to say this. Here's the other thing that I wanted to say that's related, which is um, with respect to observable phenomena. Uh, psychiatry and science and psychology has done a pretty good job of looking at or kind of narrowing in on the biochemical effects of ketamine. And so we know that a single administration done correctly leads to a week or two of symptom remittance. And a cluster or a series of ketamine treatment may give a couple months of remittance. And then we know that the symptoms tend to come back. Okay, we know that. But the problem is that we've paid entirely too much attention to certain kinds of checklists. And I think we've missed the boat or we've missed the bus here because at the same time, a lot of patients come back to us and say that they're still thinking about something that they saw or something that they realized or something that they learned in their ketamine journey, specifically in their ketamine facilitated psychotherapy or in their psychedelic ketamine journey that they're still thinking about, that they're still chewing on months later, sometimes years later. I have patients that I started seeing in 2014. And in my own case, personally, the psychedelic journey that I had in 2002. So that's, as I said, 18 or 19 years ago. It's like it was yesterday. It's so vivid and informative. And so these kinds of experiences can be very beautiful and information rich. And people sometimes tell me that their ketamine experience, their structured ketamine experience, was some of the most beautiful and informative experiences of their entire lives. So we have not done a good job of capturing this data in the scientific literature because longitudinal studies are hard to do and they're expensive. And so we don't really know how to measure, and we haven't been attentive and methodical about looking at the potential beneficial impact of this kind of working with a sacred medicine that may benefit the patient for months or years, and in some cases, decades. So it's really very exciting, and there's a lot of good research that's left to be done. So maybe I'll leave you with that thought. Let me just quickly put up my email address. And so if you have further questions, you know how to reach me. There you go. And yeah, it's really been a great honor and a pleasure to talk with you today. Thank you so much for coming.